Right, so this is a very brief introduction into pharmacology. We'll break some of these medications down later on that you'll see in the hospital, okay? But to give you a sort of a stroll back through memory lane, or an antique, would be this big, huge book right here, the PDR, Physician's Desk Reference, okay? Every medication in the United States is in this book in 1992, okay? And doctors, nurses, whoever would literally look information up here and go through. Now it's an app. You have this entire book on your telephone, right? So they went from this, which is really good, to an app where you can type in and search. I mean, the things that you can get medical-wise through an app store is unbelievable, okay? And then here, just maybe sometime during your downtime, a little bit of break or whatever, this is a nursing pharmacology book. And so you sort of go through and look at the different things in the book just to sort of see, if you're going into nursing, sort of see, hey, this is what's in my near future, okay?
Teachers, pardon the following interruption. It appears that a lot of people have not yet paid for their Gene Passes. Teachers, we really need y'all checking to make sure they have on the red wristband or the yellow wristband. If they do not have one of these passes, they need to come down to the front office and purchase a Gene Pass. Please keep in mind this is a fundraiser, so we do need to make sure that the kids are following the rules. Thank you.
Yeah, that's important. Okay, so anyhow, pharmacology, one of the things that a lot of, like I know for nursing for sure, because I've been told this, a lot of the pharmacology nursing programs, like on your medication calculations, your drug calculations, is a 100. 100 is passing. 98 would be failing. Okay? So you would have to make a 100 on your medication test, right? And so, but they prep you for it. It's just not a one-time event. It's sort of prep. But the standard is a 100, right? We don't want to make medication errors. I'm guessing on the number because it's on this other side I have for different class, but 400,000 deaths due to medication errors in the United States. Okay? So 400,000 deaths. Medication errors are huge because, to me, I think that, not to bag on the youth of today or the younger generation, but they're not as focused as us old guys used to be. And I can laugh because we still made a lot of medication errors, okay? We weren't exempt from that, but definitely the amount of focus and sort of that drive may not be there. So that may be and that's just not me. That's other people smarter than me writing about it, right? Because there has to be some reason that we make all these medication errors, right? Especially now with the app. Used to, we had, rock and chisel that we did all of our calculations on. No? Okay. But we would write them on paper. We'd write these huge medication calculations down on paper. Now you just plug it in an app and it gives you the number, okay? What I think the error comes from is not having a very good attention to detail, drawing up the wrong medicine, drawing up too much, being complacent in the amount of medicine that we draw up, all right? Anyhow, stroll through these when you get a chance, or look at the different apps. But we're going to start in the center of all this mess right here. I mean, I wrote it on the board obviously the other day, and I don't want to rewrite it, so I just put it up here. When we look at pharmacology, and you would need to do this because you would need to know hundreds of medications. All right. As a paramedic, I had about 60 to 80 medications that I was responsible for. And so the best way to do this is to put them in a class of drugs. This is sort of like a family. Right? They all look the same. So these other things will follow sort of suit if we put them all in the same class, like vasodilator, bronchodilators, right? These different medications, they sort of follow in their class. There we go. And anytime that we give a medication, we talked about this when we talked about oxygen, but we have an indication. There's always an indication for giving that medicine. I took a medicine this morning. I took an OTC, over-the-counter medicine, Mucinex, great drug. Dries your lips up. It sucks the fluid out of you so much. But if you have congestion, then Mucinex, great medication, right? The dose was 20 milliliters, whatever, at the top of that cup. I just took a shot of it and thought it was good, okay? Anyhow, and I'm still beating, my heart's still there. So you have an indication, why are you giving the medication? Contraindication, why don't you give the medication? And we'll speak of these contraindications in a moment, but there are several contraindications. The biggest one is they have an allergy to the medication, right? You can't give a patient a medication if they have an allergy to it, unless you just want to give them Benadryl and epinephrine, right? So anyway, a contraindication, we always have a dose. Every medication is based on weight, even though there's a range of the bottle on ibuprofen is 400 milligrams, right? They come in 200 milligram tablets, but the dose is 400 milligrams if you go by the bottle. I take 600 to play golf, just to take it, but you can take 800 milligrams.
Teachers, pardon this interruption. At this time, students who have a pass to go to the Texas Shakespeare Festival need to show it to the teacher in order to leave class. At this time, any student that has a pass needs to present that to their teacher so they can make their way down to the auditorium for the Texas Shakespeare Festival. Thank you.
Okay, so dose. Oh yeah, ibuprofen. But you can take it's 200 to 800 milligrams at one time. So you could take 800 milligrams if you really wanted to. You could take 800 milligrams 3 times a day. So there's a maximum dose, like ibuprofen is 2,400 milligrams. Tylenol would be 500 milligrams at a time. But then you can take it every so often, right? Every 4 hours, 6 hours, 8 hours, right? So once you learn how to take the medication and administer it, it works really well. And then you can learn, hey, this medication too, if I have a really bad headache, I can take 2 Tylenol and chase it with an ibuprofen, and that'd be okay. They're 2 different medicines. They're metabolized in 2 different ways. You can't take 3 Tylenol. You can't take 1,500 milligrams of Tylenol and still be nice to your liver. Right? That's too much Tylenol. So knowing the dosages, knowing how they interact together is very important. Okay? And so I just put, we talked about Mona last time, right? A little bit? Yeah. So nitro, 0.4 milligrams. And this is the route, sublingual. Then you would give aspirin, 325 or 324 if you're giving baby aspirin. That's oral. This beta blocker is administered IV. And then morphine, 2 to 10 milligrams, is IV as well. So when you would write this down, you would write the dose and the route down as well. When we look over here, a flashback to chemistry, just a little, what do they call this? Yeah, these are equal. You can flip these. So 1 liter equals 1,000 milliliters, or 1 gram equals 1,000 milligrams. 1 what we're looking for when we do medication administration in like an injection or something, we're looking for milligrams per cc, but that's for another day. Okay, we'll talk about that another day when we talk about giving shots. So we talk about this route. We have the dose measured in milligrams, usually. Okay, it could be measured in micrograms if it's a drip, IV drip medication. So look at the routes up here, oral, and then the onset at the same time. So we're looking at the route and the onset, either it's quick or slow onset. I know there's sort of a medium onset in there too, but we'll just talk about quick and slow. Oral medications are slow. So I take that Tylenol for my headache, and about 20 to 30 minutes later, I feel some relief. It has to enter into the GI system, break down, and absorb in that first few inches of the small intestines. Okay, so it has to be broken down. If I want this to absorb quicker, there is a way to do that, like I do. If I have a bad headache, which is not often, I take a couple of Tylenol and I chase it with some caffeine because of it's called synergistic effect. What it does is it takes that medication and it makes it work faster. Synergistic. So if I started on a task, okay, by myself, it would take me a certain amount of time to do that task, right? But if I got everybody here involved in that task, the synergistic effect of it, then I'd get my task done much quicker, right? And there's another term in pharmacology called potentiation. Say a word, so potentiation, and then potentiate would mean to increase the effects of that medication. So let's say here that we're talking about our chest pain patient, and I say, I'm going to give this patient some morphine, 2 to 10 milligrams, take your pick, okay? But morphine, Demerol, fentanyl, all these analgesic medication, pain medicines, makes the patient nauseated. So when they give morphine, they always give something that is going to help with the nausea. They don't want the patient to vomit. So they would give them, in the old days, they give them a little Phenergan, promethazine. And they sort of getting away from Phenergan now. They give them a drug called Zofran. Zofran is your friend because it's really easy on the body, doesn't have a lot of side effects. Okay? Phenergan, however, has a lot of side effects. If you give a patient Phenergan, just Phenergan by itself, they're going to go to sleep. All right? If you give me 12 and a half Phenergan, wake me up tomorrow. I'm going to sleep all day long. I'll sleep into the night. Nobody disturbs me. Okay? And if you mix that with morphine, wake me up next Wednesday. Wake me up on Wednesday or something. I mean, it would knock me out. Okay? So you learn how these medicines are combined and how they interact with each other. Okay? Phenergan is in a lot of medications. It's in cough medicine. Okay? A lot of different things. It's the class of drug is an antiemetic. It's going to stop that patient from vomiting perhaps, but one of the side effects, it really makes the patient sleepy. Okay? I used to do that. I used to do some fixed wing patient transports. Loved it. Loaded the patient on the airplane, flew for several hours, unloaded the patient, flew several hours back. It was really cool. Everything was automated, but the patient, like in an ambulance, sat in the aircraft backwards. And you know, if they're conscious, how chatty people get. So what I would do on a routine thing, because, you know, flying backwards makes you nauseated, right? Sure it does, sure. So I tell the patient, I said, I don't want you to get nauseated in the air flying backwards, so I'm going to give you a little medicine for that. So I'd give him some Phenergan. Patient would go, ooh. because I'd give it IV, and just before we would really get off the ground, they were asleep, and they woke up usually when we landed, okay, and then I had a nice quiet flight, did my paperwork, looked out the window, looked over the patient, make sure they were still breathing, right? Good to go. They slept the whole way, no chatty trip like that. So the route oral is slow. Sublingual is under the tongue, like we would give nitroglycerin. It's Latin. Sublingual is Latin for under the tongue. Thank you, Google. Okay, but it bypasses the GI tract, so the sublingual route is very fast absorption. Okay. The other route is IV, intravenous. So when they start an IV, they give the medication intravenous like you would morphine. It is a very fast onset. Nasal, remember the atomizer for Narcan? Made that mist, you squirt up the nose?
Oh,
Yeah, okay. Those nasal terminates in there, absorb that, and it is very fast. It's very fast absorption. Okay. You have intramuscular, which would be like a shot, like an antibiotic. It is a slow onset, but long lasting. So it doesn't take effect very quick, but it is longer lasting. Subcutaneous, sub-Q, is in the fat, the cutaneous tissue, the fatty tissue, okay? Don't worry, we're going to learn how to give these shots. So sub-Q or subcutaneous, all right? It is a faster onset than IM, but it's patient dependent on a couple of things. Like mainly if they're vasoconstricted, but it is patient dependent. Subdural, here is your TB shot, how you got your TB shot. Okay. It's a slow sort of onset, nothing there really to take it. And then IO would be intraosseous. Osseous would be what?
Bone.
The bone, right. So, I don't know, you guys experienced the CPR the other day? No, that was in the ICU. They didn't have an intraosseous, but they use the term drilling now. It's an easy IO. It's just a bone needle that they put literally on a little small drill, and they find the plateau, the tibia. They push it, and they push the button, and it goes zzz. Just in seconds. It's in the bone. The marrow in there is very vascular, so it's a good blood supply, and it's a quick onset. And once you're in the ER, the CPR comes in, look in the tibia for that IO. Okay, later we'll look at maybe a video of it, but that it can also go in the head of the humerus and then the sternum. They developed this during the war for fast IV access. They don't have to find a vein and get the catheter in the vein and everything. Okay, so it's a very fast onset here. So those are the routes. Don't worry, we're going to pick these. This is just a very quick intro. As we go through the different emergencies, we'll pick these back up. Okay. But so the route, this is how you would give it. And then you'd have to, one thing that you'd want to know as well is the half-life. And simply speaking, the half-life of a medication is how long it lasts. Okay? There's some medications, like a medication called adenosine or adenocard for an STV, supraventricular tachycardia. All those big words. But the half-life of it is 15 seconds. So you have to give it a very big vein. It only lasts about 15 seconds. Okay? So how long does this medication last? And then the other thing that we look at over here is the side effects. Always get these confused. You know, you got effects and effects, right? Anyhow, both of those affect somebody, right? So the side effects are what's the drug going to do? Like if you give nitroglycerin for chest pain, it's a vasodilator. And we talked about that. So what is a vasodilator going to do?
Veins bigger.
The vessel's bigger, and do what to the pressure? Drop the blood pressure, right? So it'll drop the blood pressure all the time. We'll learn more about that, why that is all the time, called Darcy's Law, and it's all the time. So if we get this vasodilator, then it's going to drop the blood pressure. We know that. That's a side effect. However, we use some of the side effects on some medications for the indication. Okay? So, like if we have a patient that has symptomatic hypertension or high blood pressure, right? We're going to treat that patient with the first round drug we may treat the patient with is nitroglycerin. We'll administer 0.4 milligrams sublingual nitro, and it will drop the blood pressure all the time, right? And later we'll learn we do have to be careful because it could drop it drastically, according to Darcy. All right. So anyhow, so the side effects, what's that medication going to do? So essentially, you need to know all these things about your medication, and you would never give a medication without knowing what it's going to do. All right? You always know what your medication that you're giving is going to do. Would you take a medication that you didn't know what was going to do? I mean, I bet you have, right? Mm-hmm. All the time. Doc goes, here, give her some of these, okay? Here, take some of these, the doctor told you. As a young adult, you need to start asking why. Okay? Think about all the medication errors out there. It is okay to ask the doctor, why do you want me to take this? Especially when you know the difference on some of the medications. Why should I take this? Okay? And an example would be Tamiflu. Okay? Click that off. Tamiflu is a antiviral medication. It just stops the virus from reproducing like in the flu. Okay? But you should ask the patient or the doctor, why should I take that? Because after about 3 days, you shouldn't take it. If you've been symptomatic for 3 to 5 days, you shouldn't take the $100 medication, that Tamiflu, because it won't do any good. You have to ride it out like a virus. You have to just ride the course out like a cold, okay? And I've had a doctor tell me that before. It's like, I can give you some Tamiflu from my son, right? I didn't have the son did, but he goes, but it's been 5 days, so it won't do any good. I'm like, don't need it then, okay? We'll just ride that boat. Treat signs and symptoms. So it does. Once you learn about medication, ask about those. Make sure, and especially make sure they're not giving you the wrong medication. If it's a new medication, read about it. They'll give you an insert when you get your prescription. Read about what that does. Okay. Anyhow, so little pharmacology here. When we look at it, it's like one of the side effects of nitroglycerin is lowering the blood pressure. So we administer the nitro, so we know that here, since if we're going to administer nitro, that we have to check the blood pressure, right? Because it's a vasoactive drug. So we want to know what the blood pressure for. So up here at the top, the minimum systolic blood pressure for nitro, we're going to go with 90. And it is 90 to 100. I think the insert actually says 80. But we're going to go 90 to 100. Hopefully both of these won't be on the exam. But if they are, go with 90. Okay? I think that's the better of the two. So we check and make sure they have at least a systolic blood pressure of 90 before we give them the medication. If they have a systolic pressure of 100, we need to really think about that. That's where the critical thinking comes in. Is they're sort of right on that edge. And once we learn Darcy's law, I keep bringing that up, Darcy's law tells us that any change in resistance has a drastic change on blood pressure. Okay? So do we change the resistance when we vasodilate?
Mm-hmm.
Yeah, why? Or how?
Because that means with the vasodilator, that means there's less pressure, and when there's less pressure, that means that there's less resistance against the walls.
Very good. Yeah. So we do change the resistance quite a bit, and that's going to drastically change the pressure at times. So we do have to be careful with that. We'll learn more about that. That's for another day. All right. Questions there? Good? This is my poor attempt at drawing a tombstone. We'll come back to that in a minute. Since it is a STEMI, yes. Yes, it is a STEMI, but it's a big STEMI, and it see how as that ST elevation goes up, it produces what sort of looks like a tombstone. I guess in October that's okay, right? But it does produce a tombstone. Why did it get the nickname Tombstone?
Because you died.
Did it? Yeah, because if that's on your 12 lead EKG, you're dying. Yeah, you get to tombstones. So as we go back through these medications, I understand that we talked about beta 1, beta 2, and alpha already, correct? We broke that down. Okay, I want to come up, and I don't know if I really explained it too much, but beta 1 affects the heart. So if you give a beta 1 medication, it's going to affect the heart rate, okay, usually in a positive way, so it's going to increase the heart rate. A beta 2 causes bronchodilation. And then an alpha property, these are all different properties of medication. An alpha property causes vasoconstriction. So when we start talking about these vasoconstrictors, they have a lot of alpha properties in them, like Levophed has an alpha, very strong, potent vasoconstrictor, and it's all alpha. No beta medication, so it's not going to affect the heart rate. Okay? The way this works is that you have a cell here that has a receptor site on it, okay? And they have a gazillion receptor sites. I just don't know a number, right? I mean, there's a lot of receptor sites on our cells. And you have, if you inject a beta drug, like epinephrine, okay? If you give the medication epinephrine, you're giving that with the intent either to kickstart the heart or speed the heart rate up. And so you inject the beta drug into them, and epinephrine has all three properties, just so you know when we talk about it later. But now, this beta cell, is that the right term to use cell? Would you say beta cell? Okay. Beta cell in there, and it looks for this receptor site on this particular cell. And those sort of, if they join up, then that's going to cause an increase in heart rate. Not just one cell, one beta cell, one beta receptor. You have to multiply that by a gazillion, okay? And then it's going to increase the heart rate. Make sense? Okay. There's a trigger that triggers these, okay? I'm not really sure exactly what, except that it's looking for this receptor. Can you help me out? Is that about right? So if you give a beta medication, what's the process? I mean, as far as that receptor site, and would you call it a trigger? It just triggers that receptor site?
So what is the beta cell exactly? Is that which one is the medication with the beta?
Like epinephrine?
So epinephrine would be the beta cell in that case?
Yeah, that beta property.
The beta property. Then it would be a ligand then instead of a beta cell.
A what?
A ligand, like a ligand, whatever you call it.
Can you spell it?
Ligand.
Ligand. And so that's what it's called instead of a cell?
Yeah, because it's not a cell, it's epinephrine. epinephrine the hormone, so it would be a ligand. L-I-G-A-N-D.
Huh?
L-I-G-A-N-D.
Oh, D.
Yeah.
Ligand.
Yeah.
Ligand.
And then the cell would be either a heart cell, lung cell, in that case.
Okay.
Yeah.
So it's not a cell, it's a ligand.
That's a ligand, but it's epinephrine. It's
Oh.
if you
So-
call ligands either hormones or like anything else other than a cell in that case.
Okay. There you go. Learn something every day. I like it. So this ligand,
Which is epinephrine.
epinephrine, okay. So it would bind up with that particular cell. Anyway, producing an increase in heart rate when we look at that. So when we give a blocker, a calcium channel blocker, what would calcium channel blocker block?
Heart rate. The heart.
The calcium receptor,
Yeah.
right? Okay, so this beta receptor, if you give a beta blocker, it's just going to put a chemical door over there, the way I describe it, so this ligand can't match up with this receptor site, okay? And then that way it blocks it. Calcium later down the road, like the 5th, 6 weeks, we'll learn about calcium channel blockers, and it blocks that because calcium's an important part of myocardial contraction, correct? Without we need the calcium, the sodium, potassium, and calcium, especially in the heart muscle. So it blocks it. Nitroglycerin is a vasodilator, would be the class. Indication is cardiac-related chest pain. Contraindication would be hypotension, blood pressure below 90, systolic below 90. There's a heart rate condition that we don't give nitro on. We think it's less than 50, greater than 100. So there's a heart rate as well. The other contraindication for nitro would be those erectile dysfunction drugs. Okay, you can't give a nitrate if someone takes an erectile dysfunction drug 24 to 48 hours. Okay. And there's possibly some other contraindications, but those are the big ones. Aspirin, indicate class is it's an analgesic, I believe. Somebody Google that for me. See what class of drug aspirin is. But what we use it for is a side effect. One of the side effects is it thins the blood down. Okay? So we use it for its side effect. The route is oral. So 325 to 324. The baby aspirin 324. Okay? So we use it to thin the blood down.
Anti-inflammatory.
Okay, anti-inflammatory. So aspirin's an anti-inflammatory. The class is anti-inflammatory, so it's in the same class as ibuprofen, right? And I'll be your friend when you're in pain. Okay, so that's oral. The beta blocker, and we don't need to know the names of the beta blockers. That's not in here. We give that IV to slow the heart rate down. We give the beta blocker to remember to decrease the workload of the heart, right? Correct? And then the morphine, the class, well, what would be a contraindication for a beta blocker?
The respiration rate or the heart rate? Their heart rate or their respiration.
Yeah, bradycardia would be a contraindication for a beta blocker. Just like nitro, it has a limit. You wouldn't give a beta blocker with anybody, a patient with below a rate of 70. Okay? And then morphine, the class of morphine is an analgesic. The indication, it has a lot of indications, but the indication that we're using it for here is cardiac-related chest pain. But we're not giving it for the pain. We're giving it to reduce preload, correct? And decrease the workload of the heart. Some of the route is IV, dose 2 to 10 milligrams. Side effects of that would be where the patient gets a little high if you give too much. But the one bad side effect of morphine, if you give it too much or too fast, the patient can stop breathing. So that's one thing to look at. And it does drop the blood pressure. It vasodilates somewhat, so it will drop the blood pressure. So those are the meds that we're looking at as far as these cardiac medications for right now. Is everybody good? Everybody good with that? No questions?
Morphine is it's not for the pain, it's for what again?
To reduce preload.
Okay.
And then MONA, you need the acronym. Cover your eyes if you have seizures.
You could have given someone a seizure.
Okay, so let's move on right quick. This won't take long because we've already done quite a bit of the groundwork, but let's talk about this STEMI, this ST elevation MI, ST elevation myocardial infarction. So we have the normal ST segment, or the normal EKG complex here, P wave, the QRS, and right here, as the picture shows, this is the ST segment. And that's what we're looking for in someone with a STEMI, ST elevation. See this dotted line right here? This would be the isoelectric line that we talked about, that imaginary line along the plane of the P wave. And we have elevation here straight up off of the isoelectric line. This would be ST depression. ST depression is a sort of an indication of ischemia. What's the difference between ischemia and hypoxia? Cell. Okay, hypoxia is low oxygen to the cell. Ischemia is low oxygen to the tissue. So this would be the cardiac tissue. So this is a sign of ischemia. It could also be a sign of a non-STEMI that we'll speak of sort of right at the end. Okay? So you have a STEMI with ST elevation. So we look at this, and it's straight up off of the isoelectric line. Now it's important here to look here at the EKG paper, because each one of these boxes, as it goes up in elevation, is 1 millimeter. Okay? So now we look at millimeters of elevation. So when we look for STEMI, we're looking at for millimeters of elevation as the ST segment elevates. Hang on. Cover your eyes again. In ST elevation, what we look for is this J point. The J point is the beginning of sort of the ST segment. See the J point here? And this J point, when it's elevated, it goes straight up like an elevator. Okay? It's not a slope. This is more of a slope here, and not really elevation. This is ST elevation. See how the J point is going straight up? And as we look at some 12 leads later, we'll look at for the J point. So when you're determining ST elevation, we always look for the J point first. Find the J point and see if it's elevated in millimeters of elevation. One little box is 1 millimeter of elevation. And so what we look for is that we do a 12 lead. A 12 lead is a diagnostic tool that we have. Okay? So we diagnose the STEMI off of a 12 lead. Other ways that they do a diagnostic off of, for a heart attack, okay, is lab work. So this person's going to come in, they're going to get all hooked up on the 12 lead, but they're also going to have lab work done. The phlebotomist is going to come draw some blood, and they're going to look for a troponin. The troponin is the main one, okay? And high troponin level is an indication of an MI. And then I don't know if they still draw the CKMBs anymore or just look at troponins, but the troponin is the main one. This is the lab they look for in MI, but these are the two labs, okay? And this is what they would also look for in a non-STEMI. So if the patient didn't have the ST elevation but had cardiac-related symptoms, what they would do is they'd go in and draw a lab and look at a troponin level, okay? So we hook them up on the EKG, the white lead, the black lead, smoke over fire, right? Snow and grass, however they do that. So the green and then the brown lead there is actually a V lead or a respiration lead. If you're just hooking up a 4 lead. A 4 lead is monitor quality. It just monitors the electrical activity of the heart. A 12 lead actually diagnoses, is diagnostic. So when we look at the 12 lead, we have this configuration here, and these are called the limb leads, okay? So they're on the arms and legs, right? Or in the chest. These, even though they're on the chest, if we set them in the right configuration, they'd be on the limbs, the legs, okay? Because this is LL, means left leg. So you actually put that on the leg, right leg, okay? So you put these on the limbs, but for monitor only, we put them up on the, just right underneath the rib cage. Okay? And then we put the 12 leads on there. The V leads or the chest leads, okay? You have V1 and 2 through 6, okay? So the way that I do this is put V1 and V2 on, then I put V4 on, okay? Because V4 goes right under the nipple. None of them go on the rib. They all go in the intercostal space, all right? So V4, and then I put V3 in between V2 and V4. I place V6 next, because that's mid-axillary, okay? And then I place V5. But it is important to have this configuration, sort of this, I don't know, what shape is that? Concave sort of shape, right? It's important to have that shape in your V leads. And what this does is it gives you different looks at the heart, electrical looks at the heart. Okay, so there's just a way to do it. You'll have plenty of opportunity to do 12 leads, so you know where the lead placement goes. So we'll pick this up later. But what it does is it gives you all these different views. You don't need to memorize this by any means, okay? But this is sort of a vector. What we call it is this V6 gives you this little slice of the heart. It gives you different slices of the heart. And it's looking for infarction sites, right? And then the limb leads do the same thing as well. They give you these different views for these different slices. It's 12 views, not 12 leads. Okay, there's only 10 electrodes. Okay, but they cross over and they provide different perspectives of the heart activity. So yes, you have, it's called a 12 lead, but there's only 10 leads, but it gives you 12 views. It's like 12 little cameras taking pictures of the heart, the myocardium, looking for infarction or ischemia, right? So that's the 12 lead EKG. So that's what we would do on if this patient comes in with cardiac related pain, chest pain, really any type of chest pain, we'd be doing they'll do a 12 lead very quickly on them, all right? So you just have these different looks here. If we were giving a 12 lead EKG class, which we will later, when we do EKG interpretation for 6 weeks, we'll revisit this somewhat, but we don't need it for now. Just understand that it's 12 views, not 12 electrodes. And then this is what we're looking at in the 12 lead. So we take this 12 lead, and this is broken down into different, it's sort of a color code. It's nice, because remember, we can have an infarction on any surface of the heart, correct? So we want to look at all the different surfaces of the heart that we can. So do you see the ST elevation here? here, and here, right? So 2, 3, and AVF, okay, have ST elevation. These are consecutive leads. These are what's called consecutive leads because they're looking at the same view. They're looking at the inferior portion of the heart, okay? So these are the same views. These are the same pictures. If you held them up together, there would be the inferior portion of the heart, okay? Does that make sense? Okay. So this person, this 12 lead here, is showing an inferior wall MI, a STEMI, because they have ST elevation in consecutive leads. Okay, the consecutive leads are the 2, 3, and AVF. See the inferior. These are the inferior leads. This is what's giving you the picture of the inferior portion of the heart. The lateral leads look at 1, AVL, B5, and 6. Okay, so that's another view of it. Septal is where? Septum. No, it's the heart.
Oh, sorry.
No, septal, the septal wall, the walls between the ventricles. Okay, and then you have anterior, which is V4 and V3. So we look at these two for an interior look. Okay? So what we're looking for on this 12 lead is ST elevation in consecutive leads. So in later, the 5th, 6 weeks, you'll have to memorize this. Okay? As far as your PCT training, you have to memorize these different leads. So 2, 3, and AVF are inferior leads. Okay, just it would do you well just to go ahead and start working on that now. We've one less thing that you have to do when we do EKG interpretation. Does everybody understand consecutive leads? Any questions there? See, these are in the same family. These are the same look. Mom, dad, siblings. They all look the same. It's the same view, right? So consecutive leads, ST elevation and consecutive leads. So you can diagnose a STEMI off of this EK12 lead because the ST elevation. One thing that it has here is called reciprocal change. See this in AVL? If you turn that upside down, what would that look like?
It would look like elevation.
Very good. It would look like ST elevation. And that's what's called a reciprocal change. Okay? And you will see the doctors or the whoever's reading the 12 lead actually do that. They'll be looking at the 12 lead right side up, and then they go, oh, okay, yeah. They have reciprocal change. That's a slam dunk that this is having a STEMI. When you have ST elevation with reciprocal change, it's a slam dunk that this is a STEMI. This person needs to go to the cath lab very quick, and that's what you'll see later when you get there. We had a student. Matter of fact, it was this here. This was a real patient, no identifiers, right? This patient came in. They did a 12 lead. Can you see the ST elevation? Mm-hmm. Boom, right? 2, 3 in AVL. Right? So they're having a STEMI. So they called the cath lab down, and the cath lab got there within minutes. In just a few minutes, this patient was off to the cath lab, and the students actually got to follow them from the ER to the cath lab. Remember the pictures back here? Oh, went too far. Saw that? Okay, then that, right? So, in this patient also has reciprocal change in the AVL. So definitely having a STEMI. Sometimes there is a question, not here because see your J point, it's straight up like an elevator in lead 2. There's no slope there. That ST segment is going straight up. Sometimes it's somewhat hard to discern that because there's maybe a slope there. Like one condition would be early repolarization. would cause a slope. But that's all for a different day. We just want to learn what a STEMI looks like. So they would start treating this patient right away for having a heart attack, and because they are, and then they get them to the cath lab as soon as possible. If this, what happens in the pre-hospital world, if this, they go out to their house, they'd run a 12 lead, they'd get this, and they would transmit that to the hospital, and then the hospital would see it, and the doctor would see it, and they go, oh yeah, they're having a STEMI. So they bring them in, and the cath lab would already be there. They would put this patient from the emergency cot onto the bed, and then they take that patient down to the cath lab. I've actually taken patients to the cath lab on the EMS cot. Faxed them in the STEMI. They said, yeah, they're having a STEMI. Rode right through the ER, straight to the cath lab. So, very, very useful in the technology where they can transmit that. So let's say we were a little delayed with the, still going the wrong way. Say we were a little delayed with the cath lab, and maybe they're at a hospital that doesn't have a cath lab, right? Now we have to transfer this patient. So we'd get them in, do the good patient assessment, start our sample and our OPQRST, right? Okay, they're having chest pain, pressure type pain, they've been shown all the good signs and symptoms of that they're having a heart attack. So we'd start our treatment. We'd evaluate the need for oxygen. Okay, remember, they're having outward respiratory distress. Or if their SpO2 is below 94%, we give them oxygen. Have to evaluate, do we give nasal cannula, do they need a non-rebreather, right? If they're in mild respiratory distress, we give what? You're right, nasal cannula, right? Mild, severe respiratory distress, non-rebreather, right? What liter flow to non-rebreather? 10 to 15. What about the nasal cannula? 2 to 6. Very good. So we evaluate the need for oxygen. We'd go ahead and give them the aspirin if they're not on blood thinners already. We don't want to thin their blood down too much. One of the side effects is they bleed out. They start bleeding. Okay. Contraindication for that would if they had a bleeding disorder already. We wouldn't give them aspirin. Man, they'd start bleeding like a faucet. Okay. The nitro, give them some nitrates, sublingual. So we're going to give them nitroglycerin, the vasodilate, what's that? Yeah. So this is our picture here. We don't have much blood flow going through there, right? So we need to thin that blood down to get through there, and we need to vasodilate that to get more blood around. And nitroglycerin also decreases the workload of the heart. So we sort of double dip it. We can give the beta blockers depending on their heart rate to reduce the workload of the heart, right? And then we administer, we give some morphine. That way we can reduce the workload again and decrease preload, which is what it does. Morphine decreases preload, which is going to decrease the workload of the heart. Everybody see sort of how that happens? Okay? The STEMI really is the mother of all heart attacks, but you do have what's called a non-STEMI. So you have this patient now that comes in with cardiac-related pain. They're having pressure-type pain. They're having nausea, shortness of breath, all the same signs and symptoms. You give them some nitro. It helps a little, but it doesn't make it go away. If it went away completely, what would you think? What would you think it was instead of a MI? Oh, yeah, I have to study. And look over your notes. Remember angina? Stable or unstable, right? Would you pronounce it angina pain? anyway, angina typically, okay, goes away with rest or nitro. The EMI pain usually doesn't go away. All right? So that's sort of the way you can start thinking down both algorithms or both tracks, okay? But anyway, so we give the nitro, the pain doesn't, or we give this non-STEMI, that's what I was on, this non-STEMI. So the pain goes away a little, but it doesn't quite go away. We do a 12 lead, there's no ST elevation, but there's ST depression in consecutive leads, okay? We draw the lab, we draw a troponin, okay? And if that troponin is elevated, then they have what's called a non-STEMI. This patient wouldn't necessarily go to the cath lab as quick as the STEMI. They would just say, okay, yeah, you're having a heart attack, okay, based on your labs and your EKG, based on the results. But and then they would get to the cath lab eventually, but it wouldn't be as emergent as a STEMI. A STEMI would be an emergent transport to the cath lab as quick as possible. The goal, I believe, is 60 minutes. So, from at the house to the cath lab to reperfusion in 60 minutes. Don't quote me on the time, but I think it's 60 minutes. I know that the ER's goal is less than 20 minutes that patient is in the cath lab. From the time that they present themselves to the ER, 20 minutes later they should be in the cath lab. All right? And usually it's much quicker than that. I've seen it just almost instantaneous. The patient walks in off the street with a STEMI. And they're starting IVs going down the hall. They're doing everything going towards the cath lab to get this patient ready. Nah, that's all. Yeah. So, for your chest pain, do a very good sample, vital signs, give support, make sure provide oxygen, do your MONA. Okay. Does everybody understand the difference between a STEMI and non-STEMI? There's just no ST elevation, okay, on a non-STEMI. As on a STEMI, there's ST elevation. So it's not always, and ST elevation doesn't necessarily mean always an acute myocardial infarction or an AMI, okay? You could have these different things here. We're not going to go into all this. But see how they give you the little, what's that called when they give you a word? An acronym? Okay. So they give you a little acronym to go. But these are just things we'll look at maybe sometime later, okay? You could have an electrolyte problem, a bundle branch block. A new onset left bundle branch block is a sign of a heart attack, okay? They're having an MI, but the bundle branch block shows up in V1. Again, that's for another day, right? Yeah, you can have an arrhythmia. I don't even know what that is. Okay, an infarct, injury, inflammation, pericarditis. What would be pericarditis? Pericarditis.
Inflammation
Right.
around
What's
the
the
heart.
pericardium? Right. The pericardial sac, the outer layer, right? Yeah. Hypercalcemia. So there's other things that could cause this ST elevation. Prince metal angina. Do y'all have this in your notes? This little thing here. Underline this, Prince metal angina. That's just Prince metal angina is spasms of the coronary arteries. Right? So the coronary artery spasm. This is the kind that you get typically at night. Right? But we give them the nitroglycerin, and then that spasm relaxes. So this is next. We'll go in. Our next stop is congestive heart failure. All right. So is everybody good with the chest pain, stable angina, unstable angina, ST elevation MIs, STEMIs, non-STEMIs? Everybody good? All right. So we